Greetings and welcome to Telemedicine Hack session number 4, Clinical Best Practices and the Art of Telephysical Exam. I'm Captain Darren Daly of United States Public Health Service and Department of Health and Human Services. This session will have medical professionals and providers who are occupational therapists, nurse practitioners from renal dialysis centers, and professors in universities. Next slide, please. As a reminder to our audience, this is a fast-paced series designed out of public health community needs for ambulatory care providers and supportive staff. This is in preparation for current and possible fall COVID resurgence. This learning module is interactive, peer-to-peer, with case studies and discussion boards. The more interactive that you are as participants, the better the experience. Our goal is to have at least 90% of our participants conduct and bill one or more video-based telemedicine visits by September 30th of this year. Slide 8. On September 9th, we'll conduct our follow-up office hours from this session and have a group of expert panelists answering your questions. Next slide, please. Our top 5 hacks are posted on the train discussion board, as is our Midpoint survey. Next slide, please. And here's our Midpoint survey. As you read the survey, I'm going to give you some more information that's not on the slide. Participant makeup, provider breakdown is 44% physicians, 15% nurse practitioners, 4 of which are presenters today, 7% nurses. Areas of specialty, 27% family and general medicine, 13% internal med, and 12% mental health substance use disorder. Our patient makeups, the patients were in settings, 25% solo private practice, like our presenter last week, Dr. Maria Barati Sanchez from New Jersey. 24% were from a group private practice, 20% FQHCs, and the other 20% academic or university hospitals. What were your challenges or barriers to video telemedicine? Patients and providers alike were challenged with technology, complexity of billing and reimbursement, and uncertainty of the permanence of telemedicine. So has our series been effective? 58% of you have implemented changes in your practice based on this series. Next up is Dr. Bruce Strumminger with Project Echo at the University of New Mexico. Bruce.
Thank you, Darren, and welcome everyone to this session of the Telemedicine Hack. Just want to go over a couple of housekeeping items. First, we want everyone to know that the data you share with us when you register, when you put questions in the Q&A, etc., that we're keeping it very carefully stewarded and confidential. And we just want you to be aware that we're taking care of it. Next slide. Hopefully everyone sees a Q&A button at the bottom of their Zoom toolbar. We really welcome your questions and comments relevant to today's session, so please put them there. And our team of experts will be monitoring that, answering the questions as we can, and we hope to answer as many of them during today's session as possible. So keep those questions coming. If you've got technical or logistic challenges, please mention those in the chat function, and our IT team will be looking there, and we'll be monitoring that as well for any issues related to things like, how do I get copies of the slides, or how can I watch the recording? And how do I get my CME or CPD credit? So we'll put all that in the chat. This session is being recorded. Your attendance is consent to be recorded. Thank you for that in advance. We will be offering CME and continuing professional development credits through the University of New Mexico, where Project Echo is based. Link should be in today's announcement, and we'll put that also in the chat about 15 minutes before we come to the end of the session. We really appreciate your feedback. So even if you don't want the CME, go ahead and complete the survey and give us your feedback so that we can continue to improve these sessions. Also, we just want to remind everyone that the purpose of these learning sessions is to improve patient care and health systems. And we want to remind all our very welcome participants to keep political and commercial comments free. We're a We want to be a political and commercial free zone. So we thank you for that as well. Next slide. Just to go over today's agenda, we're going to begin with a case presentation from Eileen Diogracias. It's going to be on the telephysical assessment in an occupational therapy practice. After her 10-minute presentation, we'll have 5 minutes for Q&A. I'll be facilitating that, and then I'll be passing the baton to my colleague, Dr. Christian Reimers, who will be facilitating and moderating the second half of today's session. We'll have a didactic on how to conduct a telephysical exam. We'll have Q&A related to that, and then we'll have a second case presentation on multidisciplinary virtual care visit at a hemodialysis center. So, and we'll have Q&A after that as well. Next slide. Great. Well, it's my pleasure to be introducing Eileen Diogracias, who is an occupational therapist with over 20 years of experience in various occupational therapy practice areas. She owns and manages Therapy Works PC, which is a pediatric outpatient therapy center in Lawrenceville, Georgia, and serves close to 250 families and provides occupational therapy, speech therapy, and physical therapy to children with special needs. She's currently serving as the Georgia Occupational Therapy Association Telehealth Chair. Eileen has also been a regular participant in the Telemedicine Hack learning series, and she'll be presenting on the telephysical assessment in an occupational therapy practice setting. So Eileen, the floor is yours.
Thank you, Bruce. And thank you to everybody for inviting me to speak today. I have been learning with all of you these past several weeks and have been directly benefited by this group. I am humbly privileged to contribute in my own small way to the telemedicine hack. Firstly, I have no known financial disclosure or conflicts of interest with the material that I'm presenting today. And as an occupational therapist and an allied medical profession, I will be using the term telehealth instead of telemedicine. Next slide, please. My goal is to encourage all of you to try a telehealth or a telemedicine visit if you still haven't jumped in. I will also be talking about how our small practice delivered services prior and during the COVID-19 public health emergency using telehealth. I will be briefly discussing how we OTs conduct our assessment using this platform. And lastly, I will be sharing some life hacks or small nuggets I picked up along the way these last few months. Next slide, please. So my small practice is called Therapy Works PC. We are an outpatient pediatric therapy center in Lawrenceville, Georgia, right in the heart of Gwinnett County. Gwinnett County is northeast of Atlanta and is the second most populous county in Georgia. Gwinnett is also one of the most diverse suburban counties in the nation. Our team is composed of 15 OTs and speech therapists, and we have been serving close to 250 special needs families since 1994. We specialize in serving medically fragile children with multiple disabilities. We provide clinic-based one-on-one therapy, but we use a collaborative, family-centered model. Our clinic is open to parents, siblings, grandparents, extended family. We had 0 telehealth visits before COVID, but I personally had experience providing school-based OT via telehealth, as well as telemedicine visits with my doctor, so I knew what I was getting myself into. Next slide, please. In May 2019, the Georgia state legislation enacted Senate Bill 118, the Georgia Telehealth Act. This seeks to modernize the Georgia Telemedicine Act and renamed it the Georgia Telehealth Act to include allied medical professions like me. It also provided for rate parity with in-person visits. However, OT was not included, so the Georgia Occupational Therapy Association created the GOTA Telehealth Task Force to advocate for inclusion. With Georgia being a largely rural state, telehealth would mitigate geographic restrictions and allow for improved access to specialists like pediatric OTs. Next slide, please. Fast forward to March 14, 2020, when Governor Kemp put Georgia on lockdown due to the COVID-19 pandemic. From a busy and growing practice, Therapy Works had no choice but to close our doors as Gwinnett County had the most number of COVID cases in Georgia. I think we're number 2 at this point, so we're on the right track. We then went to work and ramped up our advocacy efforts so that we can continue to support families and provide medically necessary therapies. It was because of this that OT was finally granted inclusion due to the telehealth flexibilities during the PHE. As a practice owner, I had to revise our workflow and create new policies and procedures while educating my therapists to transition their practice from in-person to telehealth. We had to determine the appropriate platform to use and then quickly learn it to be able to teach them the technology. We also had to learn to troubleshoot in order to make successful visits. We then had to establish an IT support protocol to address troubleshooting issues or technological issues. Last but not the least, we researched an appropriate assessment and intervention tools for best practice. Initially, all of our therapy visits were done via telehealth. At the moment, 75% of our visits are telehealth and 25% are in person, as we are trying to get back to the clinic. We are not yet at our capacity and are serving only 60% of our patients, as some decided to stop therapy altogether for the time being. But we are still here. We are open, albeit virtually. Our therapists are working, and we are continuing to serve our families. Next slide, please. At this point, I have to do my little spiel about occupational therapy. Occupational therapy is the use of assessment and intervention to develop, recover, or maintain a person's meaningful activities or occupations. As OTs, we mainly look at a client's occupational profile and how his abilities and his environment contribute or hinder his performance in daily life. We work with clients across the lifespan, and we are focused on what we call skills for the job of living. Like me, a lot of OTs work with kids. The kids don't have occupations. They don't have jobs, you say. And there is where I beg to disagree. A child's occupation is mainly to play so he can learn about himself, his environment, and form relationships with the people around him. A child can also be a student whose job is to learn concepts which prepare him for his future work. He is a son or a daughter to his parents, a sibling to his brother and sister, and a friend to his peers. Next slide, please. So our version of the physical exam is the occupational therapy assessment. I like to think of assessments as snapshots of an individual's ability to function in his environment, doing activities that are meaningful to him. This snapshot helps us determine how the person is functioning in the context of his environment and if he needs intervention or remediation. We also determine if there is a need to modify the environment to accommodate for his disability or look at compensatory strategies he can learn so that he can function. We would typically do OT assessments in the clinic. Prior to the appointment, an OT would obtain consent for a telehealth assessment, consent for assessment, and then have the families complete the intake form. Our OTs also do medical record reviews, as well as a structured parent interview to come up with an assessment plan. Parents would then bring their child to the assessment session. This is where we can conduct clinical observations or formal testing. Sometimes a child would not want to participate in an unfamiliar environment, so we would then interview the parents and ask about how he's functioning at home. The main goal of an OT assessment is to create an occupational profile and to determine how the child's functioning in his natural environment. From this, we can determine the level of disability as well as medical necessity to justify services. Next slide, please. Telehealth has allowed for OTs like me to come into the child's natural environment and not only take a snapshot, but through video, understand the environment that the child is moving in. It has allowed us to problem solve and collaborate with families on appropriate environmental modifications and accommodations to facilitate increased participation and independence. We have been able to involve family members such as dads, siblings, and extended family who typically would not be available to participate in therapy due to time or geographical constraints. With the parents' permission, we can use the recording capabilities of telehealth platforms to capture a child's level of function and use it as a baseline when we measure outcomes. I don't just have to write about how the child is doing in a written report. I can actually show you. Next slide, please. So here are my top 3 life hacks for telehealth. My best training ground for providing telehealth was teaching my 73-year-old mom how to use FaceTime. To have a successful visit, you have to be able to teach patients how to set up and use the platform. A good visit will lead to another good visit, and a bad one is probably the last. You have to learn how to use describing and positional words like the square on the upper left corner or that red button in the middle with a picture of a phone. You have to also feel comfortable with troubleshooting issues as they will come. Next slide. Anticipate that there will be pushback from clinicians, providers, patients, referral sources, and funding sources. I had to get buy-in from all of the above in order to be able to provide and be reimbursed for the service. Telehealth telemedicine is still largely unknown and unfamiliar to the population. A lot of people still think it's an approach more than a location of service. However, a lot of us know that it can be a viable option for appropriate patients. Next slide, please. I also had to tell my clinicians or encourage my clinicians to try one session and see if it is a good fit. As much as telehealth may or may not be appropriate for all patients, it may also not be a good fit for all clinicians. Professionals should also use their clinical judgment and determine if this is an appropriate approach or if assessment via telehealth is appropriate for a particular patient or situation. There may be circumstances where assessment via telepractice is not feasible or contraindicated. Next slide, please. Lastly, COVID-19 is probably the biggest event in my lifetime that has brought about changes to our practice, our community, and our world. As clinicians and individuals, we have to look ahead and be prepared to adapt to our changing world in order to survive and thrive. In our push to include telehealth in our practice, GOTA is continuing to advocate for this even after the public health emergency. Nationally, this effort is spearheaded by the American Occupational Therapy Association, or AOTA. In addition, GOTA recently conducted a survey of OT telehealth recipients throughout our state, and the overwhelming response was that Georgians want this to be a continued benefit. GOTA will continue to advocate for this as we look to the uncertain future of COVID-19. As John F. Kennedy once said, change is the law of life, and those who look to the past and present is certain to miss the future. Next slide. These are my references that I used for my presentation. Next slide, please. And if you want to connect with me, you can email me at irene.deogracias@therapyworkspc.com, or you can also find me on LinkedIn. Thank you very much.
Eileen, thank you for that terrific presentation and for sharing your wealth of knowledge and experience. We've only got a couple of minutes for Q&A right now, but let's get at it. I noticed that one of our participants also asked about this question. How do you prepare a patient in advance of their telehealth visit? And one of the participants asked, how far in advance do you prepare your patients? Any tips you have for our audience?
So what really helped our practice was front-loading the patients or the families with, we have like an FAQ sheet about what telehealth is or telemedicine, what they need to, what they can expect, what will be expected of them as what we call telehelpers, and how to set up the appointment. We probably would, when the therapist makes the initial contact with the family to schedule the service, we have a script that we use so that she can help them download the app. We use mainly Zoom, and kind of walk them through the platform. That has been really helpful to us.
Great, thank you for that. Question about whether you see telehealth occupational therapy visits becoming part of your permanent practice. How are you looking into the future and seeing things?
Well, I do not have a crystal ball, but I do see telehealth as a permanent offering in our practice and for occupational therapists. As I said, it is appropriate for some. It probably won't be appropriate for all, but I do see it as a viable option for states like Georgia, which is largely rural. It just allows for increased access to professionals, to medical professionals.
Great. Thank you, Eileen. I'm going to pass the baton now to my colleague, Dr. Christian Reimers, who's the Chief Medical Officer for Family Health Centers of San Diego, which is a network of federally qualified health centers in Southern California. I think Christian has one question for you as well before we transition. Thank you, Eileen. Christian.
Thank you so much, Bruce. Eileen, you're not off the hook yet. I've got one more that came into our Q&A from William England, and it's an interesting question. He says that kids with disabilities sometimes don't give an accurate picture in the clinical office. Do you feel like a home visit appears to give you an even better picture of what's going on?
Yes, I do agree. And like I said, we used to do home visits, but now with the telehealth option, we can actually zoom in or come into their home and see the environment where they are functioning. So yes, I do feel that having telehealth as an adjunct to the in-person service we provide would be really beneficial. In fact, that was what we were advocating for prior to the COVID-19 pandemic, when we were asking for this service to be reimbursed. Our goal was really to be able to get into the home as part of our assessments without having to travel to the home.
Great, thank you. An example of the pandemic actually causing some acceleration in where we want to go. That's a great example. Thanks for that. So we're going to mix things up a little bit and actually throw a couple of polling questions at you before we get to our didactic presenter. So Amanda, if you could bring up the 2 polling questions. The first, I'll read it out loud to you, and please do go ahead and vote. The question is, my practice currently conducts physical exams via telemedicine visits only, a mixture of telemedicine and in-person visits only, or not applicable. And we'll give you about 10 seconds to finish answering there before we broadcast the results. Go ahead and get your vote in. I think once we reach 1,000, that should probably do it. Okay, why don't we go ahead and broadcast the results now? Great, okay, so most of you, a little over half, are doing a mixture of telemedicine and in-person visits. We'll keep that in mind for the rest of the presentation. And the second polling question, we could put that up now. And I'll read it to you, go ahead and vote. It's my biggest clinical best practices question is how to set up the telephysical exam etiquette, how to prepare support staff to use telemedicine platforms, or how to measure telephysical exam efficacy and patient satisfaction. And go ahead and get your vote in. You have 10 more seconds. And I hope our next presenters are paying attention because these are good answers. All right, we are close to 1,000 responses. Why don't we go ahead and close the poll? Great, that's a little surprising. Actually, the top answer is how to measure telephysical exam efficacy and patient satisfaction. And then a second place to just kind of how to get set up. So great, thank you, Amanda, for that. We'll keep that data. And I'm gonna move things along to our didactic now. If we could close the poll and potentially bring up the slides for our next presenters. So we have 3 presenters sharing the podium for the didactic today. They have 15 minutes to get through the talk. Tina, Carolyn, and Kathy, and they're gonna talk about really how to conduct a telephysical exam. Tina Gustin is Assistant Professor and Director of the Center for Telehealth Innovation, Education, and Research at Old Dominion University in Norfolk, Virginia. And she brings 35 years of advanced practice nursing experience and is also the director of the school's Center for Telehealth Innovation, Education, and Research. Carolyn Rutledge is a professor and associate chair of nursing at Old Dominion, where she directs the DNP program, also serves as the academic director for the Center for Telehealth Innovation, Education, and Research. And Kathy Wibberly is the director of the Mid-Atlantic Telehealth Resource Center, or TRC as we like to call it. And in addition to her role there, she's the director of research for the Karen S. Rubin Center for Telehealth, assistant professor of public health sciences at the University of Virginia School of Medicine. So I'm not sure who's going first, but I will throw the microphone over to you all. Go ahead and get started.
Well, this is Tina Gustin. I am first, and if we could go to the first slide, please. I just want to say how humbled and honored I am to be here today with all of you. Eileen, your presentation was fabulous, and I'll probably refer to it a little bit as I go forward with my first set of slides. I'm also, just a side note, the clinical manager for the telehealth program at our Children's Hospital Academic Center here in Norfolk. And like you went from 0 to 100. We went from 4 providers to 400. So I can feel your pain. So in our presentation, we're going to first kind of help you to understand the process for conducting a telehealth visit. We'll discuss a little bit about how to select your equipment that you're going to need to conduct this physical assessment, be able to collect the physical data through video conferencing session without peripherals, and then utilize creative strategies to obtain that clinical data that you need for a visit. I'm going to specifically talk about the first part of a visit and particularly the telehealth etiquette. Carolyn is then going to go into the specifics of conducting an exam. Next slide, please. So let's do the key steps to a successful visit. Some of you are going to be providing these visits from your home, some your practice setting, and some from a hospital. Next slide, please. We want to make sure first, before your encounter, it's essential that you develop protocols and understand what they are. To Eileen's point, when she was starting her program, some of those protocols will include, how are you going to schedule these patients? How are you going to obtain payment for the patients? How are you going to get your consent? Sending the information ahead of time, as Eileen was specifically discussing, for example, that fact sheet. These are all protocols that need to be considered prior to even implementing your practice of telehealth. Another important aspect before you begin this encounter with patients is to decide what platform you're going to use. In Eileen's case, she used Zoom. We use Zoom at our hospital as well. When we say test the equipment before a visit, it can be as simple as turning it on, checking your audio, checking your video. And I'm going to give you some examples of visits that have gone wrong with really very simple hacks that you could have avoided. One is putting the sticky note over your camera. I'm sure many of you do that for security purposes, and you may forget about that. So when you start your visit, your patient or client will not see you on the other side of the screen. I've had that happen at our hospital setting when we're teaching new providers how to do telehealth. It's essential that you prepare your patient for the visit, and that is, do they have a camera? Do they have audio? Where are they going to do the visit? I'm going to talk about telehealth etiquette in a moment, but we also need to teach our patients on the other end telehealth etiquette. What we've run into over at the hospital numerous times is the patient will, we have a pediatric population, so the patients will sign on, the parents will sign on, and they're laying in bed, they're wearing their pajamas, they're in a dark room, they're not in a professional setting for the visit either. So they need to be prepared for this visit. What should they expect from you, and what do you expect from them? If you have IT available to you, make sure that they can help. And many of us in smaller practices don't have the benefit of having an IT specialist. We need to make sure that your consent is done prior to the visit. As you know, every state has a different regulation for a consent. What we teach our students and what we've taught our providers is just remember your state guideline. If it's a paper consent that's required, that needs to come back to you virtually. Some of our telehealth platforms will allow you to do that on the platform and others don't. It's essential that when the visit starts that you document that you have obtained a consent. And the consent is that the patient knows that this is going to be a telehealth encounter. We encourage people not to video their telehealth encounters with the understanding that you wouldn't video an in-person visit. So that's the standard that we teach at our university. Next slide, please. So let's begin the encounter. And this seems really quite intuitive when you go through the steps, but I will tell you that most of us, when we start telehealth for the first time, we forget that beginning, middle, and end of a visit that has been ingrained in our practice setting. So think about the purpose of the visit and let your patient know why you're doing this visit. Why are you conducting it, and what can they expect? Does the patient agree to this type of visit, and make sure that you chart it. It's important for you to determine who's on the side of the patient, who's in the room with the patient. Are there other people in the house? Who's in the room with you? One of the things when you're setting up telehealth encounters in a larger setting is not to do your telehealth in cubicles. You wouldn't see your patients in cubicles, so go into a private room. Put a sign on the door saying that you're doing a telehealth encounter so that people don't kind of bust into that room while you're doing the visit. Patients may also, to assure that they really are who they are, if this isn't one of your regular patients, have them show you their video or show you their driver's license so you can assure that that's who it is and where they're located. Discuss security on both ends, outline the session with them, and then tell them what the expectations are with regards to a lost encounter. That happens often. I live in an urban setting. I should have great connectivity, but my connectivity is often lost. So tell them, what are you going to do if you lose connection? Get a phone number and determine how you're going to reach them if the connection is lost. Next slide, please. So when you conduct the encounter, remember to get a history just like you would for an in-person visit. There really isn't anything different with regards to collecting the subjective data. My life hack is to practice this several times. You'll get better with each encounter because it feels really awkward when you first start doing telehealth visits. The screen is the elephant in the room, and the steps to the visit are often forgotten until you've practiced it several times. Carolyn is going to go into the strategies of obtaining a physical assessment with regards to her observation, using your observational skills and data in things that the patient might have in their home. So I'm going to leave that to her. Again, provide a plan, set up a referral, and make sure that you send notes and texts for follow-up at the end of the visit. Next slide, please. So this is really my favorite part. I love telehealth etiquette. Prior to COVID, I think everyone thought that this was pretty simple and easy, but we've all seen Zoom visits gone bad. Telehealth encounters can replicate a Zoom visit gone bad. So I'm going to give you some little simple hacks that will help you with your telehealth visits before we go into Carolyn's how do you do the exam. So next slide, please. So while we're waiting for the next slide, well, I'll tell you, as we're teaching our students, and we've had probably 1,500 interprofessional students go through our curriculum. And as we're teaching telehealth etiquette, they'll usually look at me with these blank faces and say, you know, oh, that's so simple. I FaceTime with my mother. I FaceTime with my friends. This cannot be hard. But because most of us do FaceTime, most of us have Zoomed, we have all developed kind of lazy social skills on virtual visits. So to assure that our telehealth encounters are good, let's first talk about the environment. We were chatting about our lighting before we got on as a panel and commenting on each person's, oh, your lighting is good or your lighting is good. Assure that your lighting is correctly placed. You should have natural light in front of you and not behind you. The picture at the bottom is the individual with the light that is coming in from behind them. Please eliminate your background noise. Put your dogs up. Make sure that people aren't coming down to, if you're at your home, they aren't coming down to get lunch in the middle of your visit. Make sure that you are muted when you're not speaking. That's essential. And check your surroundings. We've been doing a lot of Zoom assessments of whose background is the best when you're watching TV. You can look at all of us right now. You don't have anything behind you that you don't want your patient to see. If you have private pictures, private items, they need to be removed. If you are in behavioral health in particular, look at what's behind you. We had some settings or some situations where patients have thought that the plant that was on the shelf was actually growing out of the provider's head. So really look at what is behind you to assure that your background is what you want your patient to see. Look at your desk. Is it cluttered? If they can see your desk. So this picture is an exaggeration, but it's reality. Next slide, please. Your appearance is critical. And when we're talking about environment and appearance, I'm going to kind of throw in here. Women, we tend to primp when we're looking at ourselves in the computer. You know, we fix our hair, we put our hair behind our ear, and that can be incredibly distracting. Our clothing choices are critical. Ideally, put on a lab coat. If you can back yourself up enough so that the patient or the client can see your name or your ID badge, that's ideal. Your head placement, so my head is in the center of the screen. So for this type of visit, it's perfect. You don't want to be kind of like this, scrunched down or too far back. And eye gaze is probably the hardest thing to do. If you're working off of an iPad, the camera is to the left of the iPad. So getting your eye gaze and your head centered is really quite difficult with an iPad. On a computer, your camera is at the top of your computer and your eye gaze should really fall between the camera and the center of the screen. So what happens when you're doing that correctly, you feel like you're not looking at your patient. But when you are feeling like you're looking at your patient, for them, it looks like you're looking down. So another thing that I like to say here with the environment, another life hack, is we do a lot of charting while we're meeting with our patients or clients. And when we're in an office setting with them, they can see that you're charting. You're either charting on a computer screen or you're charting on paper. When you're on the telehealth setting and you're looking down charting, it looks like you're disinterested. So you need to tell them, I always tell individuals as I'm teaching them how to do telehealth, it's like you tell your children, use your words. You have to use your words when you're doing your telehealth encounter and say, I will be looking down charting. If I'm looking down, I'm charting, I am paying attention. Next slide, please. Communication. Pacing is critical, and it's interesting when we first start doing telehealth, probably when I first started doing this presentation, my pacing was different. My pacing has gotten better as I've gone through the last few minutes of this presentation. think about your pacing, don't speed up and don't go too slow. In telehealth, the pause that is comfortable in an in-person visit is often an uncomfortably long pause. So you have to think about the way you're pacing your visit. Individuals that are new to telehealth sometimes feel that they can't express empathy through a telehealth encounter the way they can with an in-person visit. You can. You just need to use your empathetic word choices much more mindfully. The nodding of your head is helpful. So just you have to think about the way that you're expressing empathy versus the in-person visit. Another thing that is interesting with telehealth is you can often be saying one thing but have a different facial expression, which comes across as incredibly incongruent on a telehealth encounter, where in person it's often disregarded. So think of telehealth as the TV and an in-person visit as stage acting. Stage acting is big and everything is very subtle in a telehealth encounter. Your resting face, we all have one. So when you are listening quietly, you have to think about the way that you're resting your face. Some of us look a little happier with the resting face than others. And the other thing is your listening skills. We sometimes in a telehealth, when you're new to telehealth, it's a little harder to listen rather than speak and move forward. And that really just comes with practice. Next slide. Security, we've talked a lot about security already. The privacy of the patient setting, the privacy of the provider setting, make sure that your equipment is secure, your consents are done. And with regards to the patient setting, security, and who's in the room, I was just with the provider this past week that's doing palliative care at our children's hospital with children. And she said, you know, when I'm in a room with a patient, I can have the mother step out and just have that visit with the teenager. I can't do that in telehealth. And I argued with her pleasantly that, well, yes, you can. You can always have a family member step out of a room. Ask them to step out, and you're going to know if they left or not, because the patient is going to have that affect that that person is still in the room. So those are just things you should consider as you're moving forward with your telehealth visits. Next slide, please. Obtaining your clinical data. I think Carolyn's going to go forward from here, but your video conferencing, you can use incredibly creative strategies without having your peripherals. So for those of you who are new to telehealth, a peripheral is a otoscope, a stethoscope, an ophthalmoscope. You can video conference with peripherals. We're going to have store and forward and remote patient monitoring. And Carolyn is now going to give you some tips and tricks on how to do that video exam without your peripherals. Next slide, please.
I only have about a minute left, so I'm going to touch base real quickly. One of the big areas that we're running into in healthcare is so many people were providing care without being able to give peripherals to their clients. And so we, at the end of the slide presentation, you're going to see a list of videos. We have created a list of 6 videos on physical assessment. And then we also have the telehealth videos that Tina referred to. As far as the videos when you have no peripherals, let's go to the next slide and let me run through that real quickly. Part of it is to really think about using a lot of household items. Think about using the iPhone, the mobile health on the their watch to be able to give you information. Asking somebody else to help with the presentation, but be creative. Let's go to the next slide. Examples, and these are in the videos that you can see. One is for an ENT exam. You can have the patient move their mouth real close to the slide and open up and use an iPhone or a flashlight and shine in the back of it. You can ask the patient to palpate for nodules. Say, do you feel anything that's tender? You can have them jump up and down. If a patient has peritonitis, jumping up and down, the pain will be excruciating. Have the patient cross their arms and breathe, and you can follow their respiratory rate. Have them move the camera to show you things. So one of the things we run into, we forget that we can be creative, use household items to demonstrate some of the things that we would actually do in our physical exam. Can I go to the next slide, please? Then it's always nice if you can have peripherals, and hopefully as things settle out, we will start utilizing peripherals more often to get diagnostic information, to be able to really actually look in the ears at the same time the patient holds the otoscope up, and we can become much more clear on our diagnostic abilities. Let's go to one more slide. One of the things that I think is very fascinating is some of the invasive things that can actually be done. We have a group that's known as the Health Wagon in Southwest Virginia. They actually connect on with UVA, the cystoscopy and colposcopy, the clinics there. They can actually do a cystoscopy while they're connected into UVA 300 miles away. And they can tell the nephrologist or the kidney specialist can tell them where to do a biopsy. And so they're both looking at the exam at the same time and able to get appropriate diagnostic information. And so we need to keep in mind that using some of the technology we have, we can actually continue doing things without moving the patient to that location. Sorry, I'm rushing through this. You can go on to the next slide. And one more. Again, practice makes perfect. And then to the final slide. Okay, so these are the two videos. I wanted to show you a clip from one of the videos, but they're located there. They are open access, so you can just Google there. For those that are physical therapy, we have a neuro exam, we have the musculoskeletal exam. So we show you all the tricks to being able to do the clinical exam that way. So I will turn it over to Kathy Wibberley.
Thank you, Carolyn. I think we're going to have to actually wrap this section to give Patrick some time to finish his section. But if we could go to the last 3 slides, go ahead and forward. I just really wanted to acknowledge the TRCs. Kathy Wibberley is a member of the Telehealth Resource Centers, and I also want to acknowledge we have ghost panelists that have been feverishly answering your questions. So please keep them coming in. We don't have time for Q&A after this session, but Andrew Solomon from the Northeast TRC, and then also John Scott from UW Digital Health has been answering those questions. And again, we'll have much more time to get to more questions next week. Let's go ahead another couple slides to Patrick's first slide. And thank you so much to the group from Old Dominion. So I'm pleased to introduce Patrick Hawkins. He is a physician consultant for kidney disease and hypertension consultants in Flint, Michigan. He's a senior nurse practitioner and assistant professor at Michigan State University, and has interest in chronic kidney disease, dialysis, hypertension management, and community health screening. So Patrick, take it away. Patrick, you are muted still.
There you go. Next slide, please. Hello, everyone. My name is Patrick Hawkins. Where I work at, we're in a practice. We have 5 nephrologists and 3 advanced practice nurses. I'm in Michigan. We're in the greater Flint, Saginaw. We hit urban and rural areas. And that map, you really can't see it, but our population, it goes from very rural with less than 2,000 patients to over 300,000 to 400,000. So our population is very diverse. Before COVID, it was 1%. After COVID, it's 94% that we're doing telehealth visits, and now we're doing mixed visits. Next slide, please. Next slide. Okay. And the types of service we deal with chronic kidney diseases, all stages 1 through 5, pre and post transplant management, hypertension management, and renal replacement therapy, in-center dialysis, home dialysis, and peritoneal dialysis. We do telemedicine with all of those, and it works very well. Next slide, please. Personally, I've done over 510 telemedicine visits And what I'm finding is that my no-show rate has gone down. More patients are coming, and it's been a very useful platform. The challenge, however, is there are multiple platforms because we go to multiple dialysis centers. So we use Doximity, Doxime, WebEx, Microsoft Teams, and because each facility has different criteria that they're using. Now, so these applications, you know, the limited video instability, and with multiple operators, whether it's a smartphone or a tablet or your desktop, that's a challenge. And the biggest thing that we found works out best for us is the support staff. They will make or break your visit. Your first line, whether it's in the office with the medical assistants or in the dialysis units with the medical professionals that are there, they have to know the software. Otherwise, the visit doesn't go off. It's just you're spinning your wheels. And what we found out is have the staff troubleshoot and share the solutions among each other so you're not constantly reinventing the wheel. Next slide, please. What I found, which was the hidden obstacle for those patients that's not in the dialysis center, you need good broadband access. Otherwise, it kind of pauses and pixelates. And what I found out for some of the elderly is they have very limited data plans. And for the economically challenged, they have limited data plans. So we found creative solutions. We found Wi-Fi hotspots that are free. And you can do it in socially distanced. That's at the McDonald's parking lot, the Taco Bell, Xfinity hotspots, your local public library, Starbucks, to name a few. And what we found out is that they can do it in their car to get really good broadband, and the quality of your visit is better. And just have to remind them not to enter, because they're using open Wi-Fi, not to enter any sensitive data and close all the other apps for their security. And you have to remind them that telemedicine visits will significantly draw on the power of the device that you're using. And it draws off. And in the resources I give you, the references will tell you some of the sites where your patient can do it. And I had patients who cancel because I don't have data. So this is something that I had to do. Next slide, please. This is a case I really want to study, that telemedicine was wonderful in saving lives. This was a 54-year-old male who came in, initially complaining about fatigue and poor sleep habits. And the dialysis nurse triggered a call, which prompted the visit. If you look at this slide, he has a pretty significant medical history. And at the top of it was a history of cocaine abuse, depression, respiratory failure, MI, and CVA. So I was a little bit concerned about this gentleman. Next slide. As it turns out, he was having thoughts about committing suicide. When asking further questions, you wouldn't think eating bananas and potatoes would be significant, but when you're a dialysis patient, you consume high potassium foods, that is highly lethal. So you need to take that as significant risk, and it generated a multidisciplinary meeting. He reported feeling sad, he had suicide ideations, and he had a plan as to how he was going to commit suicide, but he didn't use cocaine, and the good thing is he actually showed up for his treatment. Next slide, please. These are his vital signs. These are his current meds. And on to the far right, he was on antidepressant. He was on Zoloft, but he hadn't been taking it for a month. Next slide, please. And this is the telehealth solution. They had a room they could set up where I could do the telehealth visit with him, provided him privacy, and we could do a one-on-one. I had his vital signs, I had his current laboratory values. I was able to share those with him, but as you can see on his PHQ-9 was 12. And since he had a plan, his suicide behavior questionnaire R, it scored 9. So that made me trigger as the advanced practice provider. So we got to do a multidisciplinary meeting with the social worker, the registered nurse, the dietitian, his primary care, and the behavior team to say, this is somebody who's at grave risk that we need to intervene on right now. So we were able to get a multidisciplinary meeting all via telemedicine. We were all 40 to 50 miles separated. Next slide, please. And when we contracted him for him not to commit suicide, for him not to do any cocaine or any illicit substances, and for him to seek immediate help if his suicidal thoughts came, and gave him the contact number for the National Suicide Prevention. And this was dealing with a local federally qualified health clinic that all these services were to be found. And he said he had limited resources, so we found a free community grief counseling, because he had watched his friend die 4 days prior from a drug overdose. So we wanted him to get some cognitive behavioral therapy that occurred immediately after his dialysis treatment, got his family members to go with him, restarted his Zoloft, which he agreed, and his family member escorted him. And the reason why we're choosing this case, dialysis patients, their risk for self-harm is exponentially higher than those who do not. And it's at 15 to 25%. So this is a real world problem. And the advantage of telemedicine, we've been able to get everyone on board and speak with his behavioral team at the Federally Qualified Health Clinic to get him a same day visit after treatment. And this avoided having to send him to the emergency room and get him the care that he needed. And I saw the gentleman yesterday. He's better. He's not suicidal. He's not homicidal, and he's coming to his treatments. Next slide, please. The take-home message for telling you about this, these are the sites where you can get your free Wi-Fi for your patients. These are the things you can do for the risk for suicide. And the take-home message, what telemedicine does in the state of Michigan, there are 30 million US clients with kidney disease. Of that 30 million, about 10% ends up on dialysis. And in the state of Michigan, there are 80,000 with chronic kidney disease. Of that 80,000, 60,000 don't know. So as we are providers, we can make a significant impact here and give them the resources, and telemedicine is an additional tool to help our clients and protect their welfare and their health. This is a wonderful asset that we can do, and we can reach out, and the challenges that we have are achievable. Just use your teams and find out what works. And if it doesn't work, don't keep repeating it, and just go on to a different one. And it allows you to empower your client. And the take home message is that we can make this happen and our clients show up better. And at that, I'd like to yield the remaining of my time to my cohorts.
Patrick, thank you. That was outstanding. And I'm just blown away by that case study that you shared. It's now been 2 weeks in a row that we've had just incredibly inspirational stories from the front line. It's a reminder that we're all learning as we go. We're all very different and diverse from different backgrounds. And thank you so much for sharing that case study. That was wonderful. As I said, we're not really able to do Q&A in this session because we're out of time, but the questions that you submitted through the Q&A box are being answered by our ghost panelists, so please continue to do that. And then a reminder, next week we'll have much more time for questions and answers at our office hours visit, so please join us then. I'm going to throw it back to Darren to close things out, and then a final word from Bruce.
Yeah, wow, really great today from our presenters. Phenomenal. I wish we had an hour and a half. I wish we had 2 hours for the presentations. I think it's the most smiles we've had, probably from our presenters as well, too. So just a reminder, please consider visiting prior sessions and our updated discussion boards on the Train website. Next slide, please. And we're going to be having a bonus hack actually tomorrow, September 3rd, from 12:15 to 1:15 p.m. Eastern Standard Time on telebehavioral health and integrated primary care and safety net clinical sessions, settings, and you'll be receiving an invite for that. As Christian said, next week is going to be office hours. Whatever we could not get to today will be answered next week in those office hours. We have a case presenter, Dr. Derek Nelson. He's the family physician who practices in FQHC in New Mexico. I did see quite a few questions about how do we get blood pressures, how do we monitor patients in telehealth, and he's going to be discussing that. He's going to be discussing the RPM equipment, which is remote patient monitoring equipment. And Bruce, over to you.
Thank you, Darren, and thank you, Christian. On behalf of our team here at Project Echo, Amy, Amanda, Patrick, just want to thank our presenters, fabulous presenters today, our expert panelists who've been answering away at the questions throughout the session, and in particular to our almost 1,500 participants today who joined us. So please come back next week to the office hours Q&A session related to today's topic of the telephysical exam. We'll have most of that session to focus on questions and discussion. And also please take advantage of the CME opportunity and give us your feedback so that we can continue to improve these. So thanks to everyone, take care, and we'll see you in a week.